This conference will now be recorded.
Welcome to everyone for joining us today at our virtual happy hour. It's been a while since we've all convened, and thank you so much to the Pharmacy Task Force for inviting Dr. Natalie Schmitz here today with us. She is Assistant Professor in the Pharmacy Practice Division at the University of Wisconsin School of Pharmacy. And she is here today to talk to us about use of cannabinoids for neurologic conditions. And so, without further ado, I would like to switch over the reins to Natalie so that we can get started on the very interesting topic. Thank you.
Thank you very much, Maria. Can everyone hear me all right?
Yes.
Yep, we're good.
Yes.
Awesome. Thanks. And just a little bit of addition to the background that Maria gave. When I was working on my PhD in Minnesota, I was also a medical cannabis pharmacist. Originally, I thought it would be a great way to get to know my population and my research a little bit better because it was one of the qualifying conditions, spasticity in Minnesota. But eventually it kind of developed into a very strong research interest of mine and a basis for my research program at Wisconsin. But overall, throughout this talk, we'll describe the pharmacology, the therapeutic uses, pharmacokinetics, and potential drug interactions of the two major cannabinoids, THC and CBD, as well as assessing the risks and the potential benefits of THC and CBD. So first, just a little bit on the endocannabinoid system. All vertebrate animals have this system, but in the invertebrates don't, so insects, nematodes, fungi, and plants. Genomic studies indicate that CB receptors have evolved over 600,000 million years ago. And in fact, they think that this system evolved in animals even before the plant was around. And this system is a balancing system or a homeostatic regulator. So it's sending out the neurotransmitters to all of your different body parts, making sure everything's running smoothly and confirming if anything needs to be rebalanced. When it finds a problem, it's sending the messages back to the brain for further instruction to the receptors, and that adjusts how you feel and how you think. It regulates hunger, neuroplasticity, neuroprotection. A lot of people are using phytocannabinoids for pain. It affects autonomic tone, immune response, connective tissue, and human behavior. It's unique in that it kind of communicates backwards. This sort of cell communication inhibits immune response. It reduces inflammation. It can relax muscles, lower blood pressure, and normalize stimulated nerves. It's basically when our natural endocannabinoids are going out to check to make sure there isn't too much happening before the body is receiving more stimulation. Two receptors have been identified, that's CB1 and CB2. CB1 receptors are mostly located in the CNS, so the brain and the nervous system, and that's depicted in the upper right-hand corner picture in blue. They're typically found mostly in the brain and the nervous system, but they're also found in the uterus, the testes, the gut, and the adipose tissue. CB1 receptors are found in these areas that regulate appetite, memory, fear, motor responses, and posture, including the hippocampus, the basal ganglia, hypothalamus, and cerebellum. And in fact, the human brain has more CB1 receptors than opioid receptors. But CB1 receptors aren't found in the cardiorespiratory drive centers. And this could explain some of the evidence of lack of lethal overdose from cannabis in comparison to opioids. On the other hand, CB2 receptors are primarily expressed in the peripheral tissues of the immune system, and that's depicted in that same picture in pink. So that includes the lymphocytes, spleen, tonsils, thymus, bone marrow, and the gastrointestinal system. There's a third human cannabinoid receptor that's in the process of being characterized, and that's GPR55. So there's endogenous and exogenous endocannabinoids. The two best characterized endogenous cannabinoids are anandamide and 2-arachidonoglycerol. There are some other minor endocannabinoids that have been identified, but overall these endocannabinoids act as those retrograde synaptic messengers at neural synapses, and they're produced rapidly near the site of action, allowing a quick localized signal. And once they're not needed anymore, they're rapidly broken down by fatty acid amide hydrolase, or FAAH, and this reduces unwanted side effects. On the other hand, we have synthetic or phytocannabinoids. Some of the phytocannabinoids, the most common ones, are THC and CBD. Some synthetic cannabinoids include Marinol, Nabilone, and Sativex. These have a larger volume of distribution, so they have a more global effect, and the effect is often longer. That often causes unwanted side effects. They are metabolized by the liver and not at the site of action in comparison to the endocannabinoids, which can lead to those more long-lasting effects. So just a brief history of cannabis in general. There's a number of different records, but the earliest written description of cannabis is 1500 BC, and that's in the Chinese Pharmacopoeia. The use of cannabis for the purpose of healing, there's also evidence from it in Egypt, India, the Middle East, and in Greece. In 1611, the Jamestown settlers brought the hemp plant over to the US, and hemp fiber was a very important export. In 1621, a popular English mental health book recommended cannabis to treat depression. In 1652, there was another medical book that indicated it used hemp to treat gout or knots in joints, which is probably arthritis. In fact, even George Washington and Thomas Jefferson grew hemp. Kind of a fun fact. In 1840, there was an Irish physician who was one of the first to introduce cannabis into Western medicine as a treatment for tetanus and other convulsive diseases. At approximately the same time, there was a French physician who experimented with the use of cannabis in the treatment of mental health disorders. Pharmacopoeias have listed marijuana to treat a number of different conditions, including neuralgia, tetanus, typhus, cholera, rabies, dysentery, alcoholism, opiate addiction, anthrax, leprosy, incontinence, gout, convulsive disorders, tonsillitis, and menstrual bleeding. In 1911, Massachusetts was the first state to outlaw cannabis, and in 1930, the Federal Bureau of Narcotics was established. In 1936, a movie came out called Reefer Madness, and that highlighted some of the stigma of cannabis. And the Marijuana Tax Act, following that movie, effectively made possession or transfer of marijuana illegal throughout the U.S., unless it was for a medical or industrial use. The Controlled Substance Act in 1970 assigned cannabis to a Schedule I classification, indicating its high potential for abuse and no accepted medical use. Other Schedule I medicines that you might be aware of, LSD, heroin, and peyote. There's a number of different attempts to reschedule cannabis, but so far those have not been successful. But in 1996, California was the first to legalize cannabis for a medical purpose, and that kind of started a movement. So this is currently the regulations of cannabis by state. The states with a dark green are states that have recreational and medical cannabis programs. The states with the kind of more traditional green have medical programs, and those with the white stars in those green states are states that require a pharmacist involvement in these medical programs. And then the light green or almost yellow states have CBD or low THC programs. And the gray states have no policies in place. Just a little bit about the plant's anatomy. So the hemp plant has many different uses other than the cannabinoids. Although CBD and other cannabinoids are found in the leaves and flowers, not in very high concentrations. So the leaves, flowers, and stalks are mostly used for textiles, and the seeds can be used for nutrition. They contain very little cannabinoids. However, the flowers and the trichomes on those flowers are where the majority of the cannabinoids are found. So these translucent resin that coats the cannabis bud is what is referred to as those trichomes. And these are clear and bulbous. They're rich in those cannabinoids, and they also exude aromatic oils, which are known as terpenes. We'll kind of get back to some of the effects of these cannabinoids and terpenes. But first, going over a little bit of the botany of the cannabis plant. There's a lot of confusion about the difference between hemp, cannabis, marijuana. So in general, cannabis is a broad term that's used to describe all of these products. Cannabis sativa is the recognized formal botanical taxa. And then there's a number of different varieties within that. For example, cannabis sativa, indica, and ruderalis. Some people characterize, or vendors may say, that sativa has high THC, indica has mixed THC and CBD, and ruderalis is a high CBD plant. But these concepts are often much too simplistic and can often be inaccurate. So there's a number of different cultivar names that are applied to these domestic plants, but they've undergone years of breeding to try to get a certain percentage of THC or CBD. So Haze and the others listed on that same line are thought to have high THC content. ACDC and others on that line are thought to be CBD dominant. However, there's been so much crossbreeding and these plants have not been properly stabilized typically. There's a lot of batch to batch inconsistencies, making these names pretty much meaningless. So the best way to know what you're getting in these plants is to get the chemical profile, whether it's the amount or the percentage of cannabinoids and terpenoids in that product. Over 100 cannabinoids have been identified from the cannabis plant, but those of most therapeutic interest right now are THC and CBD. And we'll get into those in more detail throughout the talk. But just a little bit on these terpenoids. They're thought to have some therapeutic potential, and they're found in many different plants. So myrcene is also found in mango, thyme, and lemongrass. It's thought that it has antiseptic and anti-inflammatory effects. Chirophyllene is also in black pepper, cloves, cinnamon, oregano, basil. That's thought to reduce alcoholic cravings and have some anti-cancer properties. Linalool, found in lavender, has anti-anxiety and antidepressant effects. Pinene is in pine needles and sage. That's thought to be a bronchodilator and mood stabilizer. Humulene is one of the most common. That is thought to be antibacterial and antitumorous. And limonene is found in citrus rinds and juniper and peppermint. It's thought to have stress relief, antidepressant, anti-anxiety, and antifungal effects. There's a number of different proposed pharmacologic effects of cannabinoids. Some of the best literature available is for anti-analgesic and pain relief. There's also antispasmodic, Sativex approved in Europe and a number of other countries. So there's evidence for those with MS or spasticity disorders as an anti-anorexic, antiemetic, neuroprotectant, potential anti-tumor effects. There's evidence that it's an anti-inflammatory. THC is also bronchodilatory, and we'll get into a lot of this in more depth throughout the presentation. There's also a large amount of evidence for anti-seizure, anti-convulsant activity. But more specifically about THC as a molecule, it was discovered in 1964, and it is psychoactive. It works as a lock and key kind of mechanism, binding directly to the receptors and mimicking the endocannabinoids. So THC displays cannabinoid receptor dependent and independent actions. It's a partial agonist of that CB1 and CB2 receptors. This activation of these CB1 and CB2 receptors causes inhibition of adenylyl cyclase activity. It closes voltage-gated calcium channels. It opens inwardly rectifying potassium channels and stimulates mitogen-activated protein kinases. THC does have that stigma of psychotropic effects. That's mostly mediated by the CB1 receptors. However, oftentimes these CB1 receptors are necessary for mood effects, improving mood, improving appetite, potential analgesic effects, and there are thought that THC is also anti-inflammatory and neuroprotective. THC does have an active metabolite that undergoes first-pass metabolism, but it is 4 times more psychoactive than THC, which is important for the oral route of administration. There's a lot of common adverse effects with THC and this stigma that comes along with it. Some major ones to point out are paranoia or anxiety, cognitive impairment that may include altered sense of time or dysphoria, just general dryness, which could include dry eye, dry mouth, redness in the eye. It could cause sedation and a number of these other potential unwanted effects. Although THC is psychoactive, there's a number of other non-intoxicating cannabinoids. We're going to talk more in depth about CBD and its effects, but you can see here there's a lot of other potential therapeutic cannabinoids. So CBD was discovered in 1940, and it lacks the cannabis or THC-like intoxicating properties. CBD is thought to be an anxiolytic, antidepressant, has analgesic properties, neuroprotection, anti-inflammatory, and antioxidant. It works to increase the amount of endocannabinoids in your system by altering the way the enzyme works. For example, it inhibits the FAAH that breaks down anandamide, allowing more anandamide endocannabinoid to work in your system. CBD is also a negative allosteric inhibitor of CB1. That helps reduce some of the psychomimetic effects of THC, increasing the therapeutic potential of THC. It's also an antagonist to the third cannabinoid receptor that's being characterized, that GPR55. CBD is also an agonist of TRPV1 and serotonergic receptors and glycine. It regulates calcium flux. CBD does have a larger volume of distribution and it can be found in many different tissues. This can result in some different side effects. Some of them include fatigue, changes in mood, or dry mouth. The most common side effect is diarrhea. However, it's possible that that is due to the amount of oil consumed because these cannabinoids are lipophilic. So if they're consumed orally, they need to be combined with a lipophilic substance. So the diarrhea could be a result of too much oil consumption. So before we get into the clinical uses of these different cannabinoids, I'd like to review the pharmacokinetics of these different routes of administration and formulations. So cannabinoids can be used through inhalation, whether that be smoking or vaporizing, oral ingestion, edibles, oral solutions, sublingually, that could be lozenges, a sublingual spray, a tincture, and topicals, a cream, ointment, maybe a patch. But each of these different routes of administration have a different pharmacokinetic profile. This kind of research is challenging with these cannabinoids due to the low analyte concentrations, the rapid and extensive metabolism, and it's difficult to separate some of these compounds of interest from biological matrices and from each other. Like I said before, THC and CBD are both highly lipophilic, so it distributes highly into perfused tissues and then later into the fat. Inhaled and IV routes of administration would be the fastest and correspond best with Cmax. On the other hand, oral Cmax is often earlier, but the onset of the pharmacodynamic effect is later. So smoked or vaporized and inhaled routes of administration will have the fastest onset of action of 5 minutes and a duration of roughly 2 to 4 hours. Oral routes of administration typically have an onset between 30 minutes and 2 hours and lasts for usually 8 hours. And then sublingually, the onset of action is 15 or so minutes, with it lasting 2 to 4 hours. The faster the onset of action, the more amenable to titration this will be, because the patient will be able to recognize if they have the effect that they want to relieve the symptoms. But if the onset of action is longer, they're at risk for taking in too much and having unwanted side effects. So to go over a little bit more specifically on each of these routes of administration, there's variable bioavailability when the THC reaches the lungs. So whether inhaled or vaporized, anywhere from 20 to 70% of THC is reaching the lungs. But it has been shown that that vaporizers are more efficient at delivering cannabinoids compared to smoking. And then there's also less tar and other potential irritants in the vaporizer. But even of what reaches the lungs, only 30% of that reaches systemic circulation. This is, again, the shortest onset of action other than IV, making dose self-titration more simple for the patient. However, when you're inhaling, you can have potential irritants. So if someone has asthma or a similar disease, that they may not be able to use this route of administration. Another route of administration, oral. Again, that could be oral solutions, capsules, or edibles. This has a delayed onset of action. And with THC, you're getting 50% of it metabolized to that active metabolite before even entering systemic circulation. So some patients may claim that this feels stronger than another route of administration. In addition, you have that longer effect, but there's low and erratic gastroabsorption. If this is, at least with CBD, if it's taken with food, that increases the bioavailability and is more consistent. Sublingual route of administration, that can come in a spray, a tincture, a lozenge, or an orally disintegrating tablet. That'll have mixed absorption. Some may be swallowed, other passes through the mucosal membrane. This may be a good option for something like nausea in a patient that cannot use an inhaled route of administration, but also cannot take an oral route of administration due to their nausea. Topical route of administration has very little data behind it. The pharmacology is not well understood, but it is available over the counter right now in creams, ointments, and transdermal patches. There is evidence of systemic absorption. Some patients have also taken this rectally. The onset of action is about 10 minutes. Stable bioavailable suppositories have been formulated, but there's very little available information on it. Being that medical cannabis is legal in a number of different states, there's a lot of different conditions that are in clinical practice. The main one is pain, whether that be acute pain, chronic inflammatory pain, or neuropathic pain. Could be used for mental disorders, cancer, different GI disorders, insomnia, headaches, as an alternative to opioids, spastic disorders and autoimmune disorders, one being MS, neurodegenerative disorders, glaucoma, skin diseases, epilepsy, autism, Tourette's, and HIV/AIDS. We'll highlight a couple of these different conditions and the evidence behind them. So pain is the most common condition cited for medical use of cannabis. In fact, a survey in 2016 of Michigan's medical marijuana program suggests that medical cannabis in pain patients was associated with 64% reduction in opioid use. So some patients are using it to replace conventional pain medications. There are 5 different reviews of THC and CBD for pain. They have consistent conclusions that there's a modest effect of these cannabinoids on pain. A number of different randomized controlled trials, mostly focusing on THC, whether plant-derived or synthetic, and they looked at a number of different kinds of pain. It's suggested that the plant-derived cannabinoids increase the odds of improvement in pain by 40%, and that there is a dose-dependent effect. But while the use of cannabis for the treatment of pain is well supported by these controlled trials, very little is known about the efficacy, dose, routes of administration, and potential side effects. So more research needs to be done in this space and with most of the other clinical uses. Seizures also have a lot of evidence behind them. There's some preclinical evidence for THC and CBD for the prevention of seizures. CBD also has that anti-inflammatory and anticonvulsant properties. Epidiolex was approved for 2 rare seizure disorders, Lennox-Gastaut and Dravet. So it has the clinical evidence behind it, at least for those 2 disorders, and there's some anecdotal evidence for generalized seizures. CBD, again, has that significant immunomodulatory activity and induces anti-inflammatory effects in several in vivo experimental animal models of diseases involving T cells, such as collagen-induced arthritis, autoimmune diabetes, and autoimmune hepatitis. CBD administration did improve clinical symptoms and reduced CNS immune filtration, microglial activation, and axonal damage in a mouse model of MS. And all clinical studies that have been done in the MS population have surrounded THC and CBD combination, so that's Sativex, in a 1-to-1 ratio for analgesia and antispasmodic effects in this population. But there is that preclinical evidence that there's protective effects of CBD in MS. For neurodegenerative disorders, there are effects that support the potential use due to its neuroprotective role in Alzheimer's disease and Parkinson's disease. For Alzheimer's disease, there's a preclinical study that prevented symptoms of social withdrawal and facial recognition deficits, and it reversed spatial memory deficits. And an in vitro study exhibited neuroprotection against beta amyloid. In Parkinson's, there is a preclinical study demonstrating that CBD reduced motor and cognitive impairments in the rat model that studied tardive dyskinesias in model of Parkinson's disease. There is a clinical study that demonstrated no differences in the UPDRS, plasma BDNF, or magnetic resonance spectroscopy, but there was a significant improvement in the Parkinson's disease questionnaire, which is primarily self-perception of improvement. There was an improvement in dystonia in a small clinical study of 5 people, and that was 20 to 50%. And there was also improved sleep, and that improved sleep was for increased sleep time and less sleep fragmentation. Overall, the data supporting CBD use in Alzheimer's disease only consists of preclinical evidence. For the evidence for Parkinson's disease, there's some clinical evidence, but there's a small sample size and there's very few studies. These did demonstrate promising effects in preclinical models, suggesting a more in-depth evaluation needed for the clinical utility of CBD in these disease states. There was a randomized controlled trial for CBD and Huntington's disease, but there weren't any positive effects found. Cannabinoids have been also suggested as promising substances for reduction in brain damage. Cannabinoids have been shown to modulate exocyticity, inflammation, and toxic nitric oxide production following ischemic events. Studies with CBD have shown reduced acute hypoxic ischemic brain damage by reducing glutamate, interleukin-6 concentrations, and tumor necrosis factor alpha, cyclooxygenase 2, and nitric oxide synthase production or expression. One study in hypoxic ischemic newborn piglets suggests that CBD and hypothermia could be complementary and have additive effects. So preclinical data indicate that CBD administration following a cerebral ischemic event produces long-lasting neuroprotective effects, and that's largely due to calcium homeostasis effects and reduction in inflammation mediation formation. However, at this point, there's no clinical data available. There's some evidence for cannabinoid use in nausea and vomiting. Nabilone and dronabinol have been approved for nausea and vomiting associated with chemotherapy, and these studies demonstrated that THC was superior to placebo and equivalent to available antiemetics. On the other hand, there's some preclinical research available that suggests CBD also suppresses nausea and vomiting, but this is a biphasic effect. So at low doses, it may suppress vomiting, but at high doses, it may potentiate it. There's limited evidence for anorexia and weight loss. Specifically, CBD has no appetite-inducing effects. In fact, one preclinical study in rats showed a decrease in appetite after CBD administration for 14 days. There's some evidence for oral cannabis in increasing weight in patients with HIV-associated wasting syndrome or anorexia nervosa. But one could think that this is perhaps components of the plant in addition to THC that contribute to the effects of cannabis on appetite and food intake. There haven't been any randomized controlled trials studying the effect of plant-derived cannabis on appetite and weight gain as being the primary endpoint. There is some studies evaluating the effect on sleep of these different cannabinoids. THC is often used to induce sleep because it decreases time to sleep and has been shown to improve sleep quality. A combination of THC and CBD could increase wakefulness. And for sleep, again, CBD has that biphasic effect. So at low doses, it may increase total wake time, but at high doses, it could induce sleep time and increase length of sleep. CBD has also been shown to positively affect REM sleep disorder, which is when a patient may act out their dreams, such as shouting, talking, or complex movements that are associated with those nightmares. So the effect may depend on the dose, the time of administration, and the combination of THC to CBD. So definite conclusions at this point aren't possible due to the differences in these studies' qualities and assessment methods. So more research needs to be done. For anxiety and depression, there's some evidence that CBD improves anxiety symptoms, and this was assessed by a clinical test with the stimulus being public speaking. However, daily cannabis use is associated with increased anxiety symptoms. And then for depression, there's no clinical trials available to assess the effects of cannabinoids for major depressive disorder. There's some evidence for anti-tumor effects. THC slowed the growth of lung and breast cancer and a leukemia model in mice. This is thought to be caused due to two different mechanisms: apoptotic death and inhibition of tumor angiogenesis. There was one small clinical trial, and there have been several preclinical studies that have found anti-tumor effects on glioma. In a phase 2 clinical trial, glioblastoma patients that were treated with both chemotherapy and cannabis, those in the treatment arm at 1 year had an 83% survival, in contrast to those in the placebo arm that had a 53% survival rate at 1 year. Oftentimes, these studies use very high doses of THC or CBD or both. There's some evidence behind neuroblastoma, astrocytoma, glioblastoma, and glioma that there's a mean decrease in tumor size, at least preclinically, 50 to 95%. One study did demonstrate that higher doses of THC are more effective and that there's a dose-dependent relationship. However, currently there's no efficacy studies or reliable case studies available, and there's insufficient evidence to make a conclusive statement. But as far as negative effects for causing cancer, THC and CBD are not likely associated with lung cancer or head and neck cancer, but there is some moderate evidence that frequent and chronic use of cannabis smoking is linked to testicular tumors. For respiratory disorders, long-term cannabis smoking could cause more bronchitis episodes, but when cannabis is stopped, the respiratory symptoms improve, and vaporizing cannabis compared to smoking often causes fewer respiratory symptoms. A cross-sectional study using the NHANES data found that frequent and heavy marijuana use causes no adverse events in specific lung function. In fact, acute use could increase forced vital capacity, but that's not true with chronic use. Cannabis is also not associated with the development of COPD. Some case reports have associated cannabis with acute coronary syndrome, arrhythmias, sudden cardiac death, cardiomyopathy, transischemic attack, and stroke, but this association remains unclear. Acutely, THC can cause tachycardia, but chronically, cannabis users could develop bradycardia. There can be changes in blood pressure with THC. High doses can cause orthostatic hypotension, but acutely it could also increase blood pressure. There is that risk of angina. There has also been an association between cannabis use and the development of schizophrenia and other psychoses. This is kind of a chicken and the egg scenario. Is it that cannabis causes or brings out these psychosis disorders, or is it that those with these underlying conditions are more likely to seek out these substances, or is it just timing? Because oftentimes use of recreational products coincides with schizophrenia onset. However, those that have been diagnosed with schizophrenia or some of these other psychoses that have a history of cannabis use have been linked to better performance on learning and memory tasks. But with other disorders such as bipolar, daily cannabis use could increase their symptoms. On a positive note, THC use or cannabis use has not shown any increased likelihood of developing depression, anxiety, or PTSD. So just a little bit on drug safety, especially with THC. Some of the contraindications: acute psychoses are an unstable psychiatric condition because it could potentiate some of those symptoms, specifically in bipolar disorder. If there's severe unstable cardiopulmonary disease, if someone is pregnant or breastfeeding, there are some reports of preterm labor and low birth weight, and cannabinoids are expressed in the breast milk. and if someone has a history of alcohol or substance abuse disorder. Other precautions to take if they're have a severe condition cardiovascularly, immunologically, liver, or kidney diseases, if they have a history of arrhythmias, a personal history or family history of some of these psychiatric disorders, potential drug interactions that we'll go through on the next slide. Cannabis has also been associated with hyperemesis syndrome, which is mostly seen in heavy long-term cannabis users. And one of the hallmark symptoms for that is scalding hot showers, specifically directed on the neck, which is pretty unusual, and it will eventually self-resolve, but oftentimes these patients need IV fluids. And avoid use in pediatric and elderly patients. So going over some of those drug-drug interactions. Clinical data for THC and CBD drug-drug interactions is lacking. The most evidence for these drug interactions is with CBD due to the approval of Epidiolex. So it's been looked at in a couple different anti-seizure medications. So specifically, co-administration of CBD with clobazam have resulted in no changes in the parent molecule, but there was an over a 3-fold increase in the metabolite, and this increase is associated with adverse effects that are typically associated with clobazam, lethargy, sedation, ataxia. So often dose reduction is needed. There's been a study of stiripentol in CBD that slightly increased exposure of stiripentol, but this likely isn't clinically significant. There's also a study with CBD and valproate, but there's no significant effect. There's some in vitro and case studies that have demonstrated THC and CBD's inhibition of warfarin metabolism, leading to an increased INR and bleeding risk that have required warfarin dose reductions. There also could be a pharmacodynamic interaction of additives, CNS depressant effects with alcohol and benzodiazepines. I've listed some of the enzyme effects of CBD and THC. So a number of different potential interactions could be predicted from these causes. One important thing to consider if a patient is requesting information on over-the-counter cannabis is to make sure that the product isn't contaminated. These products soak up everything in the soil. In fact, they're planted all around Chernobyl to try to purify the soil there. So once the cannabinoids are extracted, they could contain different pesticides, heavy metals, fungal and bacterial pathogens. So it's important to educate the patient on that the label should say how much of each cannabinoid is present, evidence that there are none of these contaminants, and that there's a lab seal of approval on their packaging. This is just a summary of the different level of evidence behind these different conditions, as well as either if THC or CBD has a positive or negative effects on these different conditions. Overall, kind of the theme that you've probably heard me say is we need more research, but there's a lot of challenges with this research because a lot of these conditions are vulnerable populations or they're children, which make experimental designs challenging. There's limited funding and there's these regulatory barriers with the legality and the schedule of these substances. Standardization and quality of these products is very variable, and long-term outcomes are at this point unclear. So thank you for your time. Sorry I took up a couple extra minutes, but I'd like to invite any questions you guys have at this point.
Thank you, Natalie. If anyone has questions, it's a small group. You can just pipe in, or you can type in the chat box below. Very informative presentation. Natalie, what do you envision for the near future in terms of the use of cannabinoids in medicine?
It seems that it's being more and more widely accepted. Um, the problem that, or I guess concern that I have with that is there isn't the efficacy evidence behind those uses yet. So I hope that more research is funded and available to support these uses. I definitely think there's a role for the use of cannabinoids in therapy, but I don't think it's the miracle cure that a lot of patients think it is.
Natalie, I have a question as Alex. What about, you mentioned in your talk about the lack of consistency in the products available and the potencies and whatnot. Do you see any movement toward not governmentally regulating it, but somehow, are there any medical or pharmaceutical companies stepping up to standardize this in any way to give practitioners at least peace of mind as to, if you're getting so many milligrams, it's actually that, and then the variations between is there any standardization happening in the industry?
Well, a couple of, maybe a month ago now or two, the FDA had a public hearing on cannabinoid and cannabinoid products, and that was a common theme, that there needs to be some sort of guidance or standardization. One thing that it seems more companies are moving towards is third-party testing, at least for the over-the-counter products. But you're absolutely right. There was a JAMA article a couple years ago that I think said, roughly 30% of these over-the-counter CBD products are accurate, and then maybe a third above and a third below. So it is kind of the Wild West out there, but I think the FDA will move forward with some sort of guidance, I hope. But then also there's the pharmacologic available drugs such as Epidiolex or Sativex, I would expect to come to the US at some point. And those are going to be much more regulated, being FDA approved.
Thank you. This is a challenge for us in our hospital system, and the reason why we've basically outlawed, or even though California does allow it, there's no safe way that we can assess the clinical effects of whatever it is that they are ingesting or rubbing on.
Yeah, absolutely. And that is one thing with the Minnesota program that I was a little bit more comfortable with, because it is tested and then audited by the state. So you know exactly how many milligrams of each cannabinoid are in that product. But I think without that, that would be a major concern.
Are there any other questions? Okay. Thank you so much again for joining us. And Natalie, thank you for sharing your expertise with us. And looking forward to the next virtual happy hour, which is scheduled for September 19th. And that is specifically hosted by our movement task force. So you will see a notice about that. But on behalf of the Stroke ISIG, we would like to thank Natalie for doing this for us today for ACRM. Thank you so much.
Thank you, everybody.
Thank you. Bye.
Bye.